Start. Dr. NEENA.
Posterior capsular surprises in pediatric cataract surgery. Pediatric cataract is challenging because of its high risk of complications, and managing the posterior capsule is of utmost importance in maintaining a clear visual axis. Here we share a series of cases which pose challenges in the way of posterior capsular management. Case 1 is that of a 2-year-old male child who came to us with intermittent inward squinting since birth. Anterior segment showed this deep AC with a central globular appearance of the lens resembling a subluxation. Ultrasound B scan showed a conical protrusion of the lens capsule, and we did an examination under anesthesia which confirmed the presence of a posterior lenticonus, and we decided to proceed with cataract surgery. After a careful anterior capsulorhexis, we proceeded with irrigation aspiration of the lens matter bimanually, keeping the parameters low, and post lens aspiration we found a posterior capsular opacity, and on trying to do the posterior capsulorhexis I found that there was no posterior capsule there. It was just an area of lens epithelial cells bridging the defect. So a vitreorhexis was fashioned with the vitreous cutter, and an anterior vitrectomy was done to make the posterior capsular opening and to clear the visual axis. And finally, after instilling triamcinolone acetonide to ensure that there is no vitreous in the anterior chamber and in the sections, we proceeded with an intraocular lens implantation. You can see that the anterior segment being cleared of the triamcinolone, and the 3-piece intraocular lens is being implanted. It is dialed into the sulcus, and the optics are captured under the anterior capsulorhexis. And finally, after removing the viscoelastic, the eye was closed. So posterior lenticonus is often associated with cataract and posterior capsular deficiency, and another important sign which you may find is that of the fishtail sign, which you can appreciate on moving the eye, showing the prolapsed cortex into the vitreous cavity. Case 2 is that of a child who presented with intermittent exotropia, central opacity in the form of an egg in the eye appearance, and ultrasound B scan again showing a conical protrusion of the posterior lens capsule. So suspecting a congenital posterior capsular deficiency, we proceeded with an examination under anesthesia and cataract surgery. Here you can see the cataract was almost near total, and after staining the anterior lens capsule, we are proceeding with the capsulorhexis, again trying to make a relatively smaller rhexis as compared to the usual standards, because we are expecting a posterior capsular defect in this case. So after anterior capsulorhexis, again a bimanual irrigation aspiration is done to remove the lens matter, and here soon after the central chunk of the lens matter was removed, you can see that there is a large elliptical shaped posterior capsular defect which is seen in the center, which is corresponding to the egg in the eye appearance on the torchlight examination. So the large elliptical posterior capsular defect is now visible, and using cutter and irrigation aspiration, we switch between cutter and irrigation aspiration and clear the vitreous as well as the cortex from the pupillary area and from the bag. And after doing a careful posterior capsulotomy as well as anterior vitrectomy, again a 3-piece intraocular lens is injected, it's dialed into the sulcus, and the optics are again captured in the anterior capsulorhexis margin, ensuring a good lens centration. So finally the viscoelastic is removed, and the eye is formed with saline and air bubble, and ports are secured. So here you can see the eye being sutured with 10-0 polyglactin sutures. So the child did very well, and pre-existing posterior capsular deficiency signs would be a conical protrusion of the posterior capsule with prolapsed lens matter into the anterior vitreous, and here you can see the child maintaining good alignment and a clear visual axis. The third case is that of a 1-year-old child, again with intermittent exotropia of the left eye, central cataract. Fundus was suspicious of a stalk running from the optic nerve to the posterior lens capsule, but ultrasound B scan did not show any stalk. Again, we took the child for examination under anesthesia and proceeded with cataract surgery. Again, with reduced parameters of irrigation aspiration, and a careful anterior capsular rhexis was fashioned. You can see anterior capsule stained with triband blue, and a careful capsular rhexis is fashioned. So a bimanual irrigation aspiration is planned, and the aspiration and irrigation parameters are kept very low so that in the inadvertent event of a posterior capsular deficiency or a defect, there is no sudden deepening or shallowing of the anterior chamber. And here a posterior capsular rhexis is done, and you can see the stalk running from the optic nerve head to the posterior capsular plaque, and we are cauterizing the stalk with an endocautery so that it should not bleed and produce a vitreous hemorrhage, and we need to call our vitreoretinal surgeon for help. So the cauterization is marked by the appearance of the air bubble, you can see here, and the plaque is eaten away with the cutter. So the posterior capsulotomy and anterior vitrectomy is completed, and triamcinolone acetonide is injected to ensure that there is no vitreous in the anterior chamber. The bag is good, but because the posterior capsular defect is large, again we are instilling a 3-piece intraocular lens, this time dialing it into the sulcus and again capturing the optic in the anterior capsular rhexis margin so that the IOL is centered well. So here again the optic capture is done, you can see. Anterior chamber is formed with saline and air bubble, and ports are closed. So these are intraoperative findings of the presence of the fibrovascular stalk running from the optic nerve head to the posterior lens capsule, and postoperatively child was able to maintain a good visual axis, a clear visual axis and good alignment. Thank you very much for your patient hearing.
Anyway, we need a primary posterior capsular rhexis and anterior vitrectomy, no? Whether there is deficiency or not.
Yes.
So, then any other increased risk you notice for this?
Yeah, so if you have noted, I didn't do a hydrodissection in any of these cases. So that is the point I wanted to stress, because most of the time, if you just do a hydro, the whole lens nucleus, which is anyway soft, comes out, and your surgery lens aspiration is over in a jiffy. But in these cases, you have to be careful. Just because the lens matter is soft does not mean that it cannot have a posterior capsular deficiency or a pathology. So ideally, you have to have a good preoperative assessment. Most of these children will not cooperate for a slit lamp examination, and you should have a high index of suspicion. Do an examination under anesthesia and check your B-scan parameters very well, and so that you avoid an inadvertent lens matter drop. Even if it is small, sometimes it needs to be removed if it is significantly, large. So
can you do visco dissection instead of hydro?
In these patients, you can do, because I didn't do any hydro in any of these patients. What I do is that when I go with the bimanual irrigation aspiration, I try to tease out the lens matter, and luckily because the lens matter is soft, it will come out as a whole, and you can eat it with the bimanual irrigation aspiration.
Was there any situation in all these 3 cases you have placed the lens in the sulcus? Was there any situation in any other case where you are placed in the bag?
Yes, if the posterior capsular rhexis is, you can make it into an ideal one as you are planning it. Normally we place it in the bag. So here in these cases, in the second case, there was a very large posterior capsular deficiency which was pre-existing. So I had to convert it into, a larger one. So putting it in the bag was totally out of question. In the first and second cases also, we could have tried, but since I had to do a vitreorhexis, and vitreorhexis is definitely not as structurally and functionally strong as a manual rhexis. So I didn't want to take a chance and and you're putting a 3-piece IOL, dialing it into the bag, can sometimes, injure your further posterior capsular rexus. So a safer option definitely is to putting a 3-piece lens and capturing it in the anterior rexus, because it will ensure good stability. But regularly we plan it in the back.
How about, do you do peripheral iridectomy?
Iridectomy. I don't do iridectomy in routine cases because I'm putting it in the back. Even if I'm putting it in the sulcus, I have a good posterior capsular opening. It's very unlikely to cause a postoperative glaucoma.